Yeah, that's perfect. Yep, yeah, I am recording it. It will be stored, and you will miss probably some of the Q&A, which is the interesting part. But other than that, you should have all the content that shared by Dr. Robert Schleip and myself. Excited for today. Yes, I'm very excited as well. Okay, now we're jumping to 29. I think we may have 10 more people left, so let's give three more minutes or so, and then we can start. So we're not slowing anyone's time down here. How's the weather in Germany today?
Very nice day, but now it's getting dark.
Oh,
because
okay.
It's 6 p.m. here.
Gotcha. It's 12 o'clock noon in New York, and it's snowing today.
Ah, strange, very strange.
Yeah.
I got a friendly complaint this morning from friends in California who complained about spring or summer weather and that they would not be ready for this. So strange, yeah.
Yeah, the Californian people, they always enjoy the sunshine, so it's
okay.
less cold over there. New York it's summers can be very hot. The winter can be very cold. So very good. We have maybe 10 more people, so we're waiting for them. And let's see. Let me see if I can do a poll. We can only see half your face. Oh, yeah, that's because I'm sitting down. I will be standing, so you can see me. I have a standing desk, actually, a adjustable desk. Let me see. Now you can see me, Valerio. Just waiting for the rest of the people to join. And then today we're going to learn about fascia. Now, why is everyone interested in fascia? Because I know people in the US, everybody's lifting weights, getting big muscles. Why is everyone interested in fascia? Let me hear some of the answers in the chat.
Probably because of your work, John. You have pioneered how to include fascia emphasis into athletic training, if I'm correct.
Yes, and I will be in Canada at the Fascia Research Congress, and I'll be meeting you there
nice.
in person.
Okay,
yeah.
Nice. So for those who are already connected, there is usually every 3 years, but now it's after 4 years, the International Fascia Research Congress, where you learn all the latest developments in that very dynamic field. And now it's happening in September in Montreal in Canada.
Yes.
And I already booked my flight ticket and look forward to reconnect with all my old and new friends, including you, John.
Yes, I will be there with my good coach as well. Logical, someone watches animals move. Yes. Yes.
Nice.
Yeah, that's very true, because animals, they don't necessarily lift weights or try to make their muscle bigger. There is a condition called myostatin deficiency, which will make the muscles bigger, but those animals tend to suffer more injuries as well. So you have found approach to movement that seems to make sense to me, except Goda. Okay, that is fine. And I think we can get started. We're ready to get started. So Doctor, do you have the sharing ability right now, or?
Yes.
Okay.
So now you need to make me co-host.
Yep, I will do that.
I say thank you for this wonderful opportunity to share my own excitement and also my questions and my curiosity in the field of fascia research. Let me confess that I have not been a martial art fighter or Olympic athlete in this life. Maybe next life I have a chance based on what I have learned. I have been a body worker, mostly working with the Rolfing method of connective tissue manipulation, but also, and that maybe is related to movement orchestration, with the Feldenkrais method. And that has been my clinical background. I have been very satisfied with my hands-on clinical work for over 30 years. I also did some teaching. And then I got interested in wanting to understand what happens under my hands. And I took a sabbatical year in order to do less sessions and spend more time interviewing scientists and going into laboratories and into libraries. And that happened during the years where the preparations were happening for the first Fascia Research Congress, where I was, due to lucky connections, involved in the organization then. That was like the beginning of Western science-based fascia research at 2007 at Harvard Medical School. And when that happened and the excitement was so large then, I knew I couldn't go back, or I didn't want to go back to clinical work. And I extended my sabbatical. And then I extended it again because what I found was so exciting. So now I'm in my 15th sabbatical year, where I stopped seeing patients. I still see some patients, but the majority of my work is now based on fascia research. And let me share my slides. And I assume that the majority of you are interested to learn. Let me see. Let me get everything into Zoom condition. Yes, that you want to understand how fascia does not only affect hands-on massage and myofascial release and Rolfing, but also how it affects athletic performance. And let me already share with you the accomplishment of 3 years of hard work in the last years, not only of me as one of the 4 editors, but I think of 60 authors in the new edition of the handspring book, Fascia in Sport and Movement. So if at the end of this lecture, which will be slightly more than 1 hour, and then I'll take questions and answers afterwards, and then I'm eager afterwards to hear Chong, how he takes, I know he's very knowledgeable and he probably knows all my slides by heart and can talk as well about the research behind it, but he's one of the pioneers who has been putting that into clinical practice. And I'm looking very much forward to Chong's subsequent 1.5 hours. And then we, at the end of that, so it will be almost a half day of very informational, inspirational webinar information. And then at the end, we have a question and answer session again. So I titled my slides, Fascia in Sports and Movement, and that is a new edition of this handspring book. If you do have the previous handspring book, that was half the thickness, that was published 10 years ago, and you now pick up the new edition, you will realize, shit, I have to buy it again because so much has changed in that field. And that is due to the fact that fascia has been largely neglected. It has not been neglected, it has not been overseen, it has not been neglected totally, but it has been given a similar amount of attention and respect as you and I do with the wrapping of our Christmas presents. So the last birthday or Christmas present, it usually came in a nice wrapping. You admire the wrapping, you put it to the side, and then you assume that the iPhone or the jewelry or whatever is inside works without the wrapping. And that was the common assumption, and there is nobody to blame, because I have been doing that with all my presents also. I assume that I can understand the gluteus maximus if I free it from the wrapping around it. And everybody assumed that, because that is also what happens to the way how we open our presents. But imagine what would happen if the new iPhone that you unwrap doesn't work, and you call the hotline and they say, Dr. Schleip, where did you put the wrapping? And I say, it's down in the basement in the garbage. And then they say, would you dare to go into the garbage, because we need the wrapping in order to get this iPhone to work properly. And I would say, well, that's quite unusual. And then they say it has been in the small print, you know, in the manual in small print. And the same thing has been happening to conventional anatomists when we look at muscle functioning, for example, but also at proprioception, that it has been in the small print. Some tangential pioneers like Dr. Ida Rolfe, but also Andrew Taylor Still, who have not been gurus in mainstream medicine, but they have been known. They have been mentioning before that if you want to understand any organ, you need to study it with the fascial envelope. So when you look at the gluteus maximus, for example, and you clean it from the surrounding connective tissue, you will assume it's a one-joint hip extensor, an external rotator, and maybe an abductor. But that is very wrong, as we just learned in the last few years, because 60%, not 16, 60% of the fibers do not go from the pelvis to the femur. They go in the fascial envelope surrounding the whole thigh, in which the outer line, the IT band, in most of us, but not in all of us, carries the main tension below the knee. And then the gluteus maximus is a muscle involved in whether you have X legs, X knees, valgus or varus. It is involved not only in the stabilization of the knee joint, the tension in the knee joint capsule, it is also involved in how your foot arch is involved. So you have to completely relearn fascial anatomy if you are open for this major new insight. It's not completely new, but it has been new for many of the conventional Western-based anatomists and also sports scientists. So this is not completely new, but now we have the measurement tools in order to examine fascial relationships. They didn't exist 20 years ago. The people who were studying fascia then, they used their own body perception as a research tool, and they used their touching hands. Any osteopath has trained his hands in order to find out if the IT band on the right side is more stiff than on the left side, and whether that could be a contributing factor to runner's knee, for example. But medical doctors, they haven't trained their hands, and they want to have objective tools. For the muscles, they had EMG, little electrodes or needles, where they can measure in milliseconds. If the psoas is a biphasic muscle or one-phasic muscle, you don't need to feel it in your body or do touching. You can objectively clarify that beyond the matter of a doubt, whether it's activated once or twice in normal walking. And that was very inviting to the Western scientists, that they had objective tools. Also, they had X-rays for the bones, but for fascia, the current or the past tools were not refined enough, because most fascial envelopes are less than 1 millimeter thick. And the resolution, for example, of ultrasound was only 1 millimeter. So if your gluteus maximus on the right side, for example, had a higher tension into the IT band, and the IT band just above the knee was 30% thicker, any osteopath can palpate a thickness increase of 30% in a 1 millimeter fascial sheet. But you could not see that in ultrasound, and that has changed. And that is the main reason why now Western scientific, objective, instrument supported research, not palpatory research, has rediscovered or has started to discover fascia in its body-wide relationships. So that perspective has now led to a redefinition or a wider definition of what fascia is. the conventional or the traditional definition of fascia that not all the books have been using, but that would be the most authoritative definition in the Terminologia Anatomica. That is the most recent, but it's still 1996, so it's very old still. But that was the most the highest agreement among the anatomical societies, and so that would be like Webster's dictionary, for example, if you want to agree on a certain term. And that is important for you to know if you communicate with Western anatomists and Western MD doctors who are trained in that fragmental tradition. And there, a proper fascia is not a body-wide net, it is single patches on your body which are not connected. For example, the IT band, the iliotibial band on the outside of your thigh, most of the regions are parallel fiber. And that would be called an aponeurosis, a tendon sheet. And according to the Terminologia Anatomica, proper fascia is distinct from an aponeurosis. So those regions of the IT band where you have mostly parallel fibers, which is in the middle of the thigh, but not up in the pelvis, and also not around the knee joint where it bifurcates in the different directions, they would not be called proper fascia. And proper fascia, according to that traditional definition, are only dense, sheet-like, meaning flat, connective tissue arrangements in an irregular arrangement, so meaning not parallel, which are so large that you can cut them with a scalpel or with scissors without needing a microscope. So that is the traditional definition of fascia. And then you can have hour-long, I don't want to have them, but you could you can have long discussions whether the densest expression of the fascia profunda, the outermost dense fascial envelope around your body, on the bottom of the foot, whether you call that plantar fascia, whether you call it plantar aponeurosis, emphasizing the parallel fibers and the continuity with some muscles reaching into it. For example, the tibialis posterior, the peroneus longus, etc. And then you say it's an aponeurosis, it's not plantar fascia. Or whether you call it plantar ligament, if you want to emphasize the parallel fibers and ignore the other fibers, and you emphasize the connection from bone to bone. So you see already the disadvantages of that traditional definition if you want to study force transmission. And that is why, starting with the 2007 Harvard Medical School Conference Center in Boston, Fascia Research Congress, many of the researchers in that field, you see Tom Myers on the right, you see Carla and Antonio Stecco in the middle, you see Andre Fleming here, you see Jean-Claude Gimbertot, we have been struggling with each other to come to a common agreement on what we call fascia or the fascial net. Basically, we did not come to one agreement, but we came to two recommendations. We recommend to use the classical, very narrow definition of the Terminologia Anatomica, which I just explained, whenever you want to communicate with Western anatomical researchers and also with Western doctors who are interested in recognizing their tradition. But outside of this application, we recommend a functional definition in which all collagenous, fibrous connective tissues, which can be seen to be part of a body-wide tensional sharing network, whether you call them aponeurosis, whether you call them ligament, whether you call them joint capsules, because basically the IT band becomes part of the joint capsule, whether you call them intramuscular connective tissue, that is new, because in the old definition, the epimuseum, the tiny transparent envelope around the single myofibers, they were not included as proper fascia, but as intramuscular connective tissue. But now in this functional wider definition of a body-wide collagenous fibrous tensional network, there the intramuscular connective tissue is included. And that definition has been very much influenced by the tensegrity concept shown here. That has basically been taken over from art and then from architecture, in which the tensional elements are actually more important in their interconnections than the exact lengths of the compressional elements. So in a tensegrity structure, you can shorten any of the compressional sticks, 10% or 20%, without losing balance if the whole network is in a good balance. So that was the inspiration that we got at the Harvard Congress in 2007 from Don Ingber and others who had proven that a single cell behaves like a tensegrity structure. And he and his colleague inspired us to look at the human body from the hypothesis maybe the human body also works as a tensegrity structure shown here on the lower right. And then you can have a leg length difference of 1 centimeter and you can still be the best salsa dancer in your country and do a marathon in a very good time, because they are not the supporting structures as you would have assumed in conventional Western architecture, in which they are the weight supporting structures. So the new definition then looks at the connective tissue as defined in medicine. That would include the compressional connective tissues like the bones and cartilage, but it would then particularly look at the tensionally loaded. So the rubber bands or the membranes on the left lower picture. So the tensional elements, they are all connected with each other. And they are seen as part of a body-wide fascial system, whereas the bones are isolated from each other. They do not directly pass the compression one bone to the other bone. So basically, you can say the fascial net is what lay people call connective tissue. But when you talk with medical doctor, it is those connective tissues that have a dominance of tensional loading within them. Now, how does this matter to sports medicine? Because in the past, people paid a lot of attention to neuromuscular coordination, like neuroathletic training, or they paid attention to cardiovascular conditioning, or they paid attention to getting strong muscles. And people assumed you don't need to have a fourth pillar by emphasizing your connective tissue, because if you train your muscles, your fascia will also get stronger. You don't need to emphasize that with a separate training program. But this has been a very profound contributing research from my German research fellow Jan Wilke, where he did a systematic review. Where do the sports-associated myofascial injuries or muscle strain injuries, where do they happen? You know how common that is in soccer players to have hamstring injuries. And in most of the athletics sports, if you look at high performance, the injury rate is very high. And usually you talk about muscle strains. But if you take a microscope and look what portion of the muscle is injured, in the majority of the cases, it is not the contractile muscle fibers, it is not the sarcomeres, It is the fascial component of the muscle, the myofascial unit. So it is either in the tendon or it's in the intramuscular collagenous connective tissue. So he did that in a very recent systematic review. So yes, there are pure muscular lesions, but they are very rare. So they only make up 12.7%, and the rest are all fascial injuries, using fascia in the more functional definition that I explained before, in which not only the tendons are part of it, but also the intramuscular connective tissue. Now, if that is the case, if the majority of your sports-associated strain injuries are happening in the fascial system, then that has been your weakest link in your strengthening program. And if you want to be smart, don't continue to make your muscles stronger, because they are not the majority of your injuries. Please focus on the weakest link, and then you have a chance to be more injury-free. That is almost like a no-brainer. And many people have brains in sports science. And since Jan Wilke published that in 2019, not only Chong, not only Jan Wilke, but other people are realizing we need to study how to strengthen not only what is already strong, but what seems to be the weakest link in the loading chain, in which the majority of sports-associated injuries are happening. So that then, of course, brings up the question, what do we know about the connective tissue, and how that is involved in injury? And this, for example, is also a more recent study from 2018, in which they followed 250 college students over 2 years who were regular runners. And as you would expect, they have a high likelihood of developing Achilles tendinopathy, particularly if you run more than 3 times per week. You have a higher likelihood of Achilles tendinopathy than a couch potato. That is not why you run, but that's the trade-off you have. If you only run 2-3 times per week, you will be less often in the orthopedic waiting room. But if you run 5, 6, 7 times, that is great for your mind. It's great for your relationships. It's great for many other things, but not good for your Achilles tendon. So they wanted to find out, can we predict which of the runners, whether it's the overweight people or whether it's the people who have bad biomechanics, that would have been my prediction, or whether it's the flat-footed people or the ex-knee, the valgus runners, whether any of these features can predict if you have more than 11% likelihood. And what they found out, basically unfair, the female runners were more likely to be injured. And that is now a hot topic that I don't have time to go in this talk, but you will hear about it at the Montreal Congress, how female hormones affect the strength of the knee capsule, for example, and also the cruciate ligament and the patellar ligament. So that was known. But the surprise was none of the biomechanical factors, whether they were running in a proper style or not, influenced the likelihood of Achilles tendinopathy. I would have predicted the opposite. If you want to feel comfortable, don't do research. Continue preaching what makes sense to you. That is what most clinicians do. And you would say from the bottom of your heart, if you run with bad biomechanics, you will injure yourself more. But if you do research, it may not show up. And that's what happened here. 250 students is not a small number. And to everybody's surprise, biomechanics, at least the factors that they studied, had no prediction value. But one factor had, and that was the subsequent blood flow increase, not in the muscles, but in the Achilles tendon and in what's called paratenon. the connective tissue around the Achilles tendon. That is part of the fascia cruris. And if you're running for the next half an hour, probably several hours, there is an increased microcirculation. And apparently, the more the microcirculation is increased, the more injury protected you are. Now, that is a new insight. So then you may think whether foam rolling increases the microcirculation after running, whether a little bit gua sha rubbing can do that, whether contrast baths have a higher influence on that, or some of the vibratory massage guns. This is now what we are studying here, for example, at the Technical University in Munich. How can we induce, how can we utilize therapeutic stimulation to enhance the natural microcirculation increase that you have after running there? So that already is a very new insight that will definitely shape how runners do the recovery after their athletic performance. Another one comes from the very strong group at Berlin University. Basically, if you go into connective tissue in sports medicine, which is a new field, there are two big international groups. One is around Michael Kier at Copenhagen, and the other one is around Professor Aaron Patsis in Berlin. And this is one of the newer insights from the Berlin group there. And they followed volleyball players, female volleyball players at a very elite level, and many of them have ankle injuries, more than couch potatoes of the same age. And they wanted to find out what factors are influencing it. And they measured the tendon strength in the Achilles and the patellar tendon in these athletes and compared them over a 2-year period with other non-athletes of the same adolescent age. And of course, you can see with the athletic training, the muscles get stronger and the tendon gets stronger, as you would have predicted. And the same thing happened, but of course, to a lower degree in the couch potatoes. As they got older, also their muscles got a little bit larger and their tendons got stronger. But the main difference was in the couch potatoes, in the non-athletes, they increase in muscle force and the increase in tendon strength went parallel. Whereas in the athletes, they sometimes were non-matched. Sometimes the muscle grew faster than the tendon. And that happened in the athletes much, much more. So the adaptation to growing older and to more loading happened in a non-congruent way in these athletes who were training 5 times per week. And that is now the new explanation, that maybe the injuries happen when you have several weeks where your muscles have gone stronger, but your Achilles tendon may still take 2-3 months because it adapts slower, it grows slower to an increased mechanical loading to it. And then, of course, we want to know how can we train the Achilles tendon in its inherent capacities. Before I answer that, let me acknowledge the Japanese group. I already mentioned the Danish group around Michael Kier. I already mentioned the Aaron Patsis group in Berlin, but there is also a strong group working with ultrasound in Tokyo, in Japan. And that was shared with us at the 2009 Congress by Dr. Kawakami, who showed us in dynamic ultrasound what happens inside of the calf here on the left if somebody is jumping. So if you are jumping, like I'm doing now here on my standing desk, and you put an ultrasound head on the middle of the calf, then you don't see the Achilles tendon, that would be on the left, but you see the Achilles aponeurosis. That's a continuation of the tendon, just like the feather stem inside of a feather-like muscle structure. And what they found out is if you do oscillatory elastic recoil jumping, the sarcomeres, the diagonal muscle fibers, are not changing their length very much. They are basically almost doing isometric contractions like my thumb is doing on the right image. So my thumb is almost not moving. It's doing a minute movement in space, but the tendon and the aponeurosis is doing a large length change, and that is what you are seeing on these pictures. So when you are running, when you're hopping, then your muscle is not doing the main length change. It only has to be a rhythmic stiffening unit, just like my finger above. And then the main length change of the joint, but also the acceleration when you push off from the ground, comes from the passive kinetic storage recoil activity of the tendon and the aponeurosis and other collagenous connective tissue. So this is what they basically found. Yes, the sarcomeres are lengthening a tiny bit, but the main lengthening is happening here from the blue structures, which are the collagenous connective tissues. And they had discovered that prior to measuring it in humans in Australian kangaroos. There are some Australian kangaroos, they can jump 13 meters. That is longer than my hallway outside here is. And everybody thought they must have very powerful leg muscles because the muscles are what accelerates you. It's not the bones, it's not the ligaments, it's not your liver, it's not your arteries. The movement comes from the muscle. So if they can accelerate that much, they must have a high proportion of fast twitch fibers, or they must have a very high volume of regular muscles or mixture of it. But when they studied the muscles, they couldn't explain it. They have the same mixture of fast twitch, slow twitch as a koala bear has. And the leg muscles are not that much more powerful than a koala bear. So what makes the difference between a lazy koala bear and the kangaroo? I'm not saying every koala bear is lazy, but they couldn't explain the high acceleration until they left the muscles and they looked at the Achilles tendon. And there they found the main difference. The Achilles tendon of the kangaroo is very different than a koala bear, not the muscles, but the Achilles tendon, because the Achilles tendon has a very high elastic recoil capacity. It is close to stainless steel. A stainless steel has more than 90% recoil capacity for kinetic movement energy. And they discovered that later also in antelopes, but also in horses. And then in one primate monkey, not in the orangutan, not in the chimpanzee, not in the bonobo, not in the gorilla, but in Homo sapiens. We have kangaroo-like Achilles tendon. We have kangaroo-like patella tendon, like no other primate monkey has. And that is responsible for our specific style of locomotion. And that was a main discovery made by Dan Lieberman, one of the leading anthropologists in our age, who had been looking many years ago at the elastic recoil capacity in human legs. And the human legs, for example, if you look at the iliotibial band in a chimpanzee, they don't have an iliotibial band, but the corresponding structure that they have on the outside of the thigh, it has a very low elastic recoil capacity. So if you stretch it, most of the momentum is lost and it recoils very slowly. Whereas if you stretch the iliotibial band of Homo sapiens, it snaps back like a piston. So that elastic recoil capacity is responsible for our elegant way of running and jumping. It is not that we have, it is not mainly based on the elastic, on the contraction speed of the muscle fibers that you have there. So that was discovered in the Achilles tendon. Long ago, it was discovered in the IT band, that they are doing the same thing as I showed in the kangaroo. But recently, they were also able to show it that it's also happening in the quadriceps. So when you're running in your quadriceps, you can do the ultrasound shown here in the picture. The red thing here is the ultrasound head. So the diagonal dark gray colored muscle fibers, they are not shortening very much when you're running, but the Achilles, the patellar tendon aponeurosis, the white structure underneath, that is doing the main elastic length changes. So we do have the kangaroo-like elastic recoil capacity, not only in our Achilles tendon, but also in the patellar tendon. And unfortunately, the ultrasound does not work as well in the shoulder girdle muscles because we need reference points. But most people now assume that we have similar recoil capacity in other parts, for example, in human throwing. Humans can throw much, much more wide than any other animal can throw. And that seems to be based not only on the rotation that we have in our shoulder girdle, yes, that contributes to it, but that we also have these elastic recoil capacities, not only in our quadriceps, not only in our calf muscles, but probably also in many other large muscle groups that are responsible for throwing. So this is what they did here. For example, they found out in walking, you have the same dynamic in which the dark black line, the sarcomere lengthening, is not very high. But the dotted line, which are the length change in the tendon and aponeurosis, are much larger. So it means human walking, even it doesn't look like elastic recoil when your neighbor goes out of his house. But when you measure it, it is a bouncing movement in which the collagenous structures, similar like my finger with the elastic spring, has more length changes than the muscle fibers of the thumb that is holding the spring. That was a surprise for me. I thought elastic recoil you only have when you're hopping or running, but even walking has more collagenous connective tissues lengthening and recoiling than it has muscle fibers shortening and lengthening. But when you look at an athletic bicycling athlete, there you don't have elastic recoil. So on the bicycle, the dark black line, which are the muscle fibers, they are very strong, shortening and lengthening. And that moves you forward. Whereas the fascial elements do not change their length very much. So it means not all sports is fascia elastic recoil training. Some sports that have a steady speed, for example, on the bicycle, please do bicycle training, but don't think it trains your fascia. It is very good for your cardiovascular training. It is very good for your muscles, and you need a good cardiovascular training, and you need strong muscles. Good fascia is only part of your rent. So at least once per week, then do hopping or walking, where you are then, in addition to training your cardiovascular training, are also engaging the elastic recoil activity that you have there. And this is also shown here, where they did that more recently, where they looked in the quadriceps also, so not only in the Achilles tendon, they looked how the EMG is active, and you see that the muscle is active when it's not changing its length. So that is like the elastic recoil of the stainless steel spring that I showed before. So the muscles are active in resisting lengthening. So they are not active when they are changing their length, So the EMG is always active when you are preventing movement. So basically, your muscle activation is an isometric stiffening in walking and running. It is not what moves your joints into the forward direction. Basically, your muscle are a rhythm enhancer for the dynamic elastic recall motion, not in bicycle, but in walking and in running. And that has been clearly shown more recently. But then you may ask, what about mobility and stretching? Many people say, I train my fascia by doing regular stretching. And then you have them sports medicine friends who say stretching is not so good in athletic performance. And they remind you that at the beginning of the last century, everybody did stretching. So in the 1940s, in the 1950s, you were not allowed to do a soccer game unless you did some stretching before. I was not allowed, well, I was not alive then in the 1940s, but my parents, they were not allowed to go on a ski run unless they did some stretching before. But then in the last two decades of the last century, there were a lot of sports medicine studying, speaking against stretching immediately before an athletic performance. And many of you have heard that. And that was very convincing. If you do static stretching, 2 minutes, 3 minutes, but not 10 minutes, so very short before an athletic performance, then your athletic performance can be lower. So your jumping height is lower, your sprinting speed is more slow. And that's why many people in sports said, be careful with stretching. It is not good for athletic performance. That was state-of-the-art understanding in sports medicine 10 years ago, 20 years ago. But in the last 3, 4, 5 years, a lot of higher studies have come up that emphasize the value of regular stretching for sports performance. And they are not of the same level as the old studies, they are on a much higher level. They include the criticism that the second phase has shed a negative light. And they have shown very convincing athletes who do not stretch 2 minutes before their performance, but who stretch regularly throughout the year. They have a better sports performance, but that is not yet 100% certain because the data are large, but not yet ultimately beyond the shadow of a doubt. Most likely also it is good for injury prevention. So it means if an athlete only stretches 3 times per year, his sports performance will be lower and he will more likely injure himself than somebody who stretches 30 times per year. And both of them will be lower than somebody who stretches 300 times per year. So regular stretching is now coming back into sports medicine. And now people want to know what is the best loading duration in stretching. And also there, a new meta-study has been done. Here they look only at the increase of mobility, and you can do stretching for many other functions. For example, recently it has been shown that static stretching has an anti-inflammatory factor and an anti-fibrotic factor. So if you wanted to do that, then you would do it very different. But here they looked, if you do stretching only for or mainly for the purpose of getting more joint mobility. And they found out the main factor is how many minutes per week you stretch the associated myofascial tissues. And the sweet spot is around 5 minutes per week. If you stretch 10 minutes, your hamstrings per week, you are not getting more than 5 minutes, but 5 minutes is clearly better than 3 minutes or 1 minute. And that is quite helpful to know. But then you want to know, should I stretch once per week for 5 minutes and watch TV at the same time or meditate? Or should I do it 3 times per day for 20 seconds or whatever? And this meta study came to the conclusion the best sequence for that purpose of range of motion increase is 5 times per week, 1 minute each. And that is now very beneficial. So for sports in which joint mobility is important, for example, for a swimmer, and if you are constitutionally more of a hypomobile person, of a Viking person like me, and not of the hypermobile person like a temple dancer or bendy contortionist, then this makes a lot of sense that you say, I want to stretch my hamstrings Monday to Friday, 1 minute per day. And you can do that while brushing your teeth or whatever you do. So joint mobility is a new emphasis, and it seems to be mainly based on how elastic and how compliant your fascial collagenous connective tissues are. And there is a new measurement technology available since a few years only that is called ultrasound elastography, in which they not only look at how thick your fascial envelopes are, but also how stiff they are. And this is now a more recent study, and that has influenced many people in the yoga field in the last half a year, because that's since it has been published in a wider way. They found out that ankle dorsiflexion, so how much you can flex your foot towards your knee, that influences, for example, if you can squat on the ground. If you can only dorsiflex 60, 70 degrees out of 90 degrees, you will not be able to squat on the ground unless you cheat with high heels. Of course, then you can squat on the ground. So they found out there is a big age difference. In young people, which was average age 20 years in that study, how mobile your ankle joint is was mainly determined by the stiffness of the posterior calf myofascial connective tissue, so gastrocnemius, soleus, and their enveloping fascia. That made sense. I would have predicted that. But in the older people, average age 60 years, the stiffness of the calf had almost no influence, but the stiffness of the sciatic nerve up at the sit bone tuberosity, 19 centimeters more north. That stiffness had the main influence on how mobile your ankle joint is. And this is now a major inspiration for many movement scientists and stretching gurus, but also for manual therapists. In young people, you can use your elbow, you can use your foam roller, you can do myofascial stretching in the vicinity of the joint that you want to mobilize by doing big ironing strokes. But in old people, you should take your fingertips, not the back of your hand, not your elbow. You should take a more mischievous tool, a shorter tool, where you go for the muscular septi between the hamstrings and the adductors, for example, because this is where the neurovascular bundles and their epineurium, the fascial envelope around the neurovascular bundles, that is where they are embedded. So if you want to have more free ankle joint and you have patients around 60 years, don't waste too much time working on the posterior calf. Spend most of your time palpating and trying to loosen some of the stiffening and or adhesion. They are different things. One is how stiff the nerve bundle is in itself, whether it can elongate. The other one is whether the nerve bundle can slide in the surrounding mesh of the connective tissue around it. So both of these can limit it. And then you will focus with your stretches to stretch the sciatic nerve. So that would be the slump position, or it would be the plow position in yoga, in which you're not only stretching your calves or your hamstrings, but you also stretch the meningeal structures, the elongation of the sciatic nerve, into the dura mater, all the way even up to your neck that you have up there. And that, of course, is a very nice clinical application where you can come out of that webinar, say, now I can work more specifically based on new insights that were not available 3 years ago with these highly sensitive new measurement tools that were not available many years ago. So using these tools, here is a summary of how connective tissue adapts to loading. And in the upper graph, you see how directly after exercise, so that's happening in weightlifting, but also after running, for the next 48 hours and more, you have more collagen synthesis. So that's what you want to have, that your Achilles tendon becomes stronger afterwards than when you are, as compared with sleeping and not doing exercise. But also on the lower curve, you see that also the same fibroblasts are active to break old collagen down. So the collagen degradation is also enhanced. And you would have expected maybe that they are in line with each other, or maybe that you have more synthesis than breaking down, because ultimately that's what you want to have. But when you look at it, you see during the first 1.5 days, you have more degradation than synthesis. So that is the old paradox that hypnotized me as a child. It is very easy to break things down and to make a mess, but it takes much longer to build something new and to create a structure. So the same seems to happen also for the fibroblasts. They can break down old collagen much more rapidly, but to build new collagen requires more time. So that means if you do weightlifting, if you do running, if you do hopping and walking every day, you have an increased likelihood, not certainty, but an increased likelihood that you may weaken your Achilles tendon, because after 24 hours, you have more collagen taken off than you had time to create new. So based on that, if you want to make your Achilles tendon more resilient, more elastic recall capacity oriented, and less and more injury protected, you would not do hopping exercises every day unless you are used, because then you could have a left shift in that curve. But then you have the same problem if you exercise twice a day. But for most people with the metabolism that they have, it would be better to do hopping exercise Monday, Wednesday, Friday. And then you had time to break down old collagen, but to replace it with new collagen that you have in the tissue. And then the question is, how strong should you load? Not the muscles. We know the muscles grow stronger the more heavily you load them. But how about loading the tendon if you want the tendon to become stronger? And they found out if you load the tendon only with 50% 1 repetition max, that is sufficient to make the muscle grow. For example, in old people with osteoporosis, you don't want them to do 100% of maximal contraction force. So they do weightlifting with 50% and the muscle grows, but of course not as rapidly, but still the muscle gets stronger, because muscle adaptation is like a dimmer. The more you load it, the more rapidly it grows. But if you load it halfway, it will grow, but not as rapidly. But fascia training is more like a flip switch. And that was a surprise. If you load it 50%, it doesn't grow 50%, it grows 0. Nothing happens. You need to irritate the fibroblasts to get them out of their comfort zone, and then they create more new collagen fibers. So that is also a danger now, because you need to load the fibroblast or the Achilles tendon with 70–80% of maximal force capacity. And if you then had an espresso too much in the morning, and you had the exact right loading yesterday, but today you exaggerate, not knowingly, because you had some great music on or whatever, and you exaggerated 20 or 30%, you may already cause Achilles tendon injuries. So the threshold needs to be high, but not too high. So that is a reason why many of the fascial recoil trainings that the Swedish gymnasts did 100 years ago, when they did bouncing and swinging exercises, they got not banned, but they got avoided, not in athletic training. In plyometric, you still had that, but in health-oriented training, in exchange for weightlifting, because much less people get injured in proper weightlifting in a gym or on a spinning bike than you would have if you do bouncing exercises. Because for bouncing exercises, you need to load them a little bit below the injury. And that means you need personal instruction if you want to start bouncing in a geriatric home, which we are doing now. You cannot do that with Zoom exercises as you have done here. So this is Aaron Patsis, who I have quoted twice before, and he has been comparing several protocols, whether isometric contraction, where you contract the calf muscles for 12 seconds, and you do that several times, and you see how much does the Achilles tendon get stronger after several weeks when you do that Monday, Wednesday, Friday. And he compared it with our happy bouncing. So this is our kangaroo training, where you do elastic recoil training close to maximal capacity. And he found out both of them work, but a third protocol, which I didn't know before, that he invented, was superior to both of these tendon trainings. And now that is the state-of-the-art tendon training in order to increase tendon strength, not recoil capacity, but tendon strength. And that is the Berlin method of tendon training. You will find it at his institute in the internet. It is 4 seconds of maximal contraction, isometric contraction in your calf muscles. No, 3 seconds. 3 seconds, then 3 seconds pause, then 3 seconds again, and you do that 4 times. So 3 seconds isometric contraction, 4 times is 1 set, then you have a minute pause, and you do 5 sets. And that is not the ideal training for our cardiovascular conditioning. It's not the ideal training to make your calf muscles grow rapidly, but it is currently the most efficient loading training to make your Achilles tendon stronger over several weeks. And I find that very inspiring. And right now I'm collaborating with an association for hypermobility people, Ehlers-Danlos, Marfan disease, who are hypermobile. And they look for a loading training. And now I'm doing isometric 3-second contractions, but not in the long position, but in the short position, in order to increase the stiffness in their myofascial system based on that new protocol that he published here. So this is what you would do with the volleyball players who have this high injury rate. If you ask them, how can I match the slower weakening, the slower adaptation of their tendons to match the rapid strength increase that they have in their muscles in here. So this makes this training, 3 seconds isometric contraction, is the best one to make the tendon stiffer and more injury resistant. But now the question is, what about elastic recoil? And that is different than stiffness. And here it has been shown that if you practice elastic recoil, you get more elastic recoil. And that is very different to the protocol that Aaron Patsis showed before. Here they looked at the elastic recoil capacity in the patellar tendon and in the Achilles tendon in 3 different groups: in elite ski jumpers, in long distance runners, in professional swimmers, and in sedentary non-athletes. And what they found in the non-athletes, there was no high elastic recall capacity. That's not a surprise, neither in the patellar tendon nor in the Achilles tendon. But, and that was a surprise for many, in the athletic swimmers, they have very strong muscles. They have a very strong heart and very strong breathing capacity, but they are very poor in jumping. And the elastic recoil in the Achilles tendon is similar to a couch potato or to a koala bear. And so it means they didn't have elastic recoil, even though they had athletic training in the water for many hours per day. And that was different in the long distance runners. They had a high elastic recoil capacity in their Achilles tendon, but surprisingly not necessarily so much in the patellar tendon. But the downhill skiers, they had the highest elastic recoil capacity. Not only they had a high elastic recoil capacity in the Achilles tendon, comparable to the runner, but in addition, they had it in the patellar tendon. And if you look at what a downhill skier is doing, he is basically jumping. And it also places the emphasis on eccentric contraction. And that's what you cannot have in the water because of the resistance here. So most likely the elastic recoil, and that is what my finger had been doing, this elastic recoil pendulum I showed at the beginning of the webinar, it's resisting the lengthening, and that seems to be a major factor. When you then use a microscope, you can see a difference between the Achilles tendon in the habitual runners. They have a lot of undulation. You don't see it with the eye, but you see it with the microscope. So if you do elastic bouncing exercise, for example, skiing or running, in the Achilles tendon, you have more, it's called crimp. And that seems to be responsible for the elastic recoil. And in the sedentary people, the crimp is much more low. So yes, you have a little bit snapping back capacity, but the snapping back capacity gets much, much stronger if you are a regular skier or a regular runner, because then your Achilles tendon has this microscopic crimp undulation. And the more crimp you have, the more elastic recoil capacity you have. So now, if you want to make the Achilles tendon more strong and increase the stiffness, you do the 3-second protocol, isometric contraction from Aaron Patsis, and I would highly recommend that for the volleyball players. But if it's not about injury protection, but if it's a more elastic recoil capacity, that you have a higher jumping height, not based on the contraction speed of your muscles, but on the elastic recoil capacity, then I would recommend downhill skiing and jumping, because then the architecture, not only of your muscles, but the architecture of the tendon changes, not in 3 days, not in 3 weeks, but in about 3 months. So the architecture in tendons and fascia can change over a matter of 3 months and upwards in order to support a higher elastic recoil capacity that you have there. And this basically is now going back to how martial artists, how the Swedish gymnasts have been doing whole body oriented elastic recoil motions. And many of the exercises that we are now bringing back into the movement culture and into athletic culture, you can say, Robert, this is an old hat. My grandfather used to do that. And you see it here. But they have not been aware that in these swinging exercises with club bells and with kettlebells, etc., that they actually had been training more the collagen tissues and less the muscle tissue. So if you want to have strong skeletal muscles, yes, you need them, then please don't do swinging exercises, but do the weightlifting according to the state-of-the-art strength and conditioning training. But if in addition you want to have strong fascia, then you do the 3-second loading protocol, or you want to have elastic recall capacity fascia, then please do bouncing and jumping exercises in addition here. And let me finish with this one here, because this is a new emphasis entering the fascia training field here, based on research with turkeys. And that is a strong athletic research group in the United States around Roberts and Assisi. And they have been looking at the different load sharing between muscles and fascia in different movement coordinations. And so far, I have been only looking at what they call energy consumption, which is like the drop jump in plyometric training. So you jump from a box to the ground, and then you use that momentum, the elastic recall, to jump subsequently as high as possible. And that's comparable to the elastic recall capacity in the kangaroo. So in red, you have the kinetic energy not stored in the muscle, but in your center of weight in gravity when you are in the air. And when you then land on the ground, the most of the lengthening and the storage is not happening in the calf muscle, but in the Achilles tendon and Achilles aponeurosis, and that then accelerates you again in the air. So that is called energy consumption, but that is very different to the way how a frog jumps. When a frog jumps, he or she sits quietly on the ground, doesn't bounce, and then the movement starts not by preparatory counter movement, it starts by an explosive muscular contraction. And that is dissipated first into the tendon before. So there is a lag, the muscle contracts and your joint is not changing position. So you have a delay in the jumping movement because first you're stretching the Achilles tendon. But when then the Achilles tendon recoils, it gives you more jumping speed than you would have had if you would have transferred the length change of the muscle directly to the skeleton. So it makes for you leaving the ground a little later, but with a momentum where the frog can jump 1 meter height, even though it's only 3 centimeters small. And that is a very different fascia training where you need to initiate the movement with explosive muscles, but the explosive muscles can only allow the frog to jump 20 or 30 centimeters high, but that he can jump 1 meter high comes from the amplification. So this principle is called power amplification due to the elastic recall capacity in the fascia. So you need for that, you need strong muscles, very rapid contracting muscles. The kangaroo doesn't need that. It only needs isometric stiffening muscles. But the frog needs explosive muscles, number one, and then elastic recoil fascia and tendon. But there is a third type, and I had to learn that, which seems to be as much important in many athletic sports, and that is power attenuation. When a gymnast lands on the ground gracefully, or when your cat jumps down from the table and lands quietly on a floor without making much sound, you have dissipation of kinetic energy. You don't want to bounce upwards again afterwards. And that dissipation seems to happen in the collagenous connective tissue first, before they then go into the contractile muscle fibers. And this is what you have in decline running. This is what you have in catching a medicine ball, not in throwing the medicine ball. This is what you have in landing. And also very important, and that's where a lot of injuries in soccer, for example, happen when you're changing directions. So you run forward and then you turn to the left at 90 degrees. Then you need to dampen the forward movement as perfectly and as dissipatingly as possible. And that is where a lot of the injuries happen. Most likely that will not involve a lot of crimp in the collagen fibers, because then you would be bouncing backwards, and that's not what the gymnast wants. So you don't want elastic tendon, but you want a viscous ground substance. So that's what you put in your car into the shock absorbers if you don't want to bounce for 2 minutes after you go over a speed bumper. And this is how I have made a fool out of myself in order to learn. I had been invited to give some advice to the Olympic javelin throwing medalist here in Germany, to Thomas Röhler, and I found out he knows a lot about fascia. And I looked at him, and first of all, I used my ultrasound and found out his right pec major, of course, is much stronger than the left, and he has no interest to become symmetrical. So much for symmetry. And that was not a surprise. But the epimysium, the fascial envelope around the pec major on his right chest, in you and me, it's half a millimeter or maybe 1 millimeter. In him, it's 3 millimeters. 3 millimeters you only have on your plantar fascia. Even the IT band is only 1.5 millimeters. So that showed me that he uses a lot of the momentum from the fascia and not only from the powerful muscle fibers. But I was only aware of the elastic bouncing. So I suggested our principle of preparatory counter movement. You see that in the golf swing. So before Tiger Woods pushes his muscles forward, he bounces backwards for a split second. And that's what the kangaroo would be doing. And that's what you do in the drop jump. So you jump higher, you have more momentum of, if for a split second, not in slow motion, but it's usually for 200 milliseconds, you go in the opposite direction, not to ignite more muscle spindles, as was assumed in the past, but to get more pre-tension, not in the muscle fibers, but in the fascial envelope. And then Thomas Röhler would be able to throw the javelin spear 100 meters. That was my assumption. So I thought he is throwing the spear like a kangaroo, and he should bounce backwards before he goes forward. And he said, no, Robert, you don't understand anything about javelin throwing, because, and he expressed it different, it is like the frog jump. So he has it backwards, and he starts by an explosive contraction, of course, not by the chest muscle, but by the leg and the hip. And then the arm is the last element in the loading chain, but the contraction starts on the muscles of the leg on the left side and on the hip, abdominal muscles, pelvis, and then the wrist is the last thing where he throws it forward. So this is my very last slide for you as a take-home message. They are now using MRI, magnetic resonant imaging, to look at exercise changes, but also at age changes in intramuscular connective tissue. And what they found out is the less you use your muscles, the more intramuscular fibrosis. Here, for example, in the quadriceps, the green is fibrosis that you have inside of the muscle in addition to outside. And if you do regular exercise, you have less of that. So far, so good. But now comes the frustrating thing. Even with the same level of exercise, as you age, you have much more influence of biological aging than of exercise. So at 60 years, you have much more intramuscular fibrosis, and that's not a good thing, in the inside of your quadriceps compared with your 20-year-old son. And then the question is, if you decide to do more elastic recoil exercise, could you have a slowing down aging effect? Could you go back halfway of where you have been at the age of 20? And that is my question. How many of you would think with proper exercise, if you start doing exercise here at the age of 60, you could go back all the way? How many of you think you can go back halfway? Actually, the answer is coming here, and you won't believe this. If you do exercise at my age over 60, you can be younger than your 20-year-old son. Isn't that wonderful? Isn't fascia research something very, very nice? So the intramuscular architecture in a 60-year-old guy like me who does regular rope jumping or whatever skipping exercise, here it was regular running, is younger than a 20-year-old couch potato that you have here. Of course, that would mean you have reverse aging, not anti-aging, but reverse aging. And that applies to intramuscular connective tissue. I'm not saying it applies to tendon strength or many other features or pro and anti-inflammatory effect. But for this feature, it means how we load our fascial body can change our architecture. And now I'm a little bit over time, so sorry, Chong, but we started late. So let me finish by recognizing all my collaborators. And this is our group here in Germany. We meet twice per year and exchange our research. And we developed the slogan for us: if you want to understand the fascial connective tissue system, you have a lot of fun and you learn a lot if you try to simulate some of the architectural features of fascia in your own personality by becoming a good networker. So we are all into networking, not so much into competition and protection of mental property, but we are into sharing all our insights as much as possible, because this is what works very well currently in the international field of researchers, clinicians like John, who are taking this into athletic performance. So let me finish here. And John, should we wait with the question until your lecture, or do you want me to take 2-3 questions now? I leave it up to you.
We can start with some questions, like for 5 minutes, and then we take a break, and then we're going to start. I'm sure people have some questions. Go ahead.
Oh, let me see the chat box, but you can also, can they unmute, Chong, or do you want them to write only?
Go ahead. You can type in the chat. Let me see Q&As.
Sorry for overwhelming you.
Okay, difference in fascial turnover rate between children, adolescents, and adults in training applications.
Ah, okay. I didn't address children, I addressed adolescents, and that was a research by Aaron Patsis. So in adolescents, you have that gap where sometimes the muscles grow more rapidly than the tendon, and then you would do a specific tendon training. I'm not aware of children. I know the metabolism is stronger, so the injury repair is happening more rapidly. What else am I aware of? Children and fascial properties. That's pretty much it. In children, sometimes the tendon gets stronger, not because of more collagen type 1, but because of enzymatic crosslinks. So the tendon is several ropes in parallel, and you can make the tendon stronger by adding more parallel ropes. But you can also take the 5 or 6 ropes that you have and do orthogonal crosslinks between them, and then the rope gets stronger. And that seems to be happening when children do jumping, that they create more of these enzymatic crosslinks. And that is very different to crosslinks in adults, particularly diabetic adults, where we have crystalline crosslinks, and that's called advanced glycation, and they are not good. So in children, you have enzymatic crosslinks, and that's what gives you more resilience. And diabetes associated advanced glycation crosslinks, they are bad. So they make your Achilles tendon like a biscuit. It becomes stiffer, but also more brittle. So that is one of the main differences.
think there's another question that says, does the rebound or vibrational plate give the same impact on fascia as walking or running? Is there any studies on that?
I only know research on the Galileo plate, and that seems to have a strong effect on bone density, but also on muscle functioning. It has a very profound, so that's not the power plate, but it's the Galileo, the original plate. And that has very profound effects on cerebral palsy children, but I'm not aware of a direct effect on the collagenous connective tissues. I'm not aware. Right now we are studying vibrational devices like these fascia guns, but we are not there yet to tell you what the effect is on the collagenous connective tissues. So sorry, my answer is I don't know.
Second question there. For athletes who train 5 to 7 times a week, what are the best way and time to train recoil capacity to make sure collagen increase in the most efficient way?
That's a very good question. So if you are not an athlete, and there was a Finnish study, I jumped over the slide, but I can share it maybe at another time. They took average age 70-year-old Finnish man and did a jumping training with them Monday, Wednesday, Friday. But they did only 10 times 10-second jumping, so not very athletic. But they showed that this very short jumping was efficient to increase the elastic recall capacity in them. But if you are a master runner, you don't want to only train 10 seconds. So I would recommend you do your normal training. You continue to do that. But when you're not tired, maybe 2 times per week, probably not 3 times per week, you would do elastic recall exercises for 10 minutes. And I would recommend not to do that after weightlifting, because then you have a higher likelihood for injury. You would do it after a 5-minute warm-up. And then you would be doing bouncing and plyometric exercises, but not for a long time. And I would recommend to do that twice per week. There was a soccer study where they compared female soccer players doing bouncing exercises 3 times per week, as opposed to 2 times, and 2 times had the same efficiency. So that would be my current recommendation, that on Tuesday and Friday or Monday and Thursday or something like that, you do 10 minutes of bouncing elastic recall exercise before you're tired. So you do a slight warm-up and then you do these bouncing exercises. And then afterwards, you can still do cardiovascular exercises and possibly also weightlifting, but that's then you have to modify. But maybe we hear from John how you are integrating that, because I'm a researcher.
Right. Well, the way that I will answer that question after my presentation, so people have a better idea. But that is a very tough question to answer, because in my work, first we have to identify what is the fascial connection level of the individual. So it depends on the person's fascial connection from the feet to the glutes and core. The exercise capacity will be very, very different. Like just what you said earlier, when athletes load their muscles, there is a increase in the muscle, but not necessarily the tendon gets stronger, right? The muscle can get stronger faster. So the program has to be really individualized. And that's why we have to do assessment first. We have to understand the particular person's fascial connection level. Then we can properly provide guidance on that. So the next question is, there's a generic question that says, any research of fascia in brain?
No.
Not yet.
No,
okay.
we just dissected the brain structures. We know there is a myodural bridge, though that the rectus capitis posterior, so some of the very short neck muscles, they have a fascial connection to the dura mater inside of your bony cranium. So headaches that are not on the outside of your head, but on the inside of the head, can come from a strong myofascial tension. And then I have been playing, I have the fascia gun from Blackroll, but you have Hyperarch or whatever you have. So these tools, that is one of my favorite tools here. I'm using these on the rectus capitis muscles here in order to loosen some of the tension. And if you don't overdo it, I think it has an influence on intracranial fascial tension. And that would be a new field of research. But theoretically, it's clear. Yes, the very tough connective tissue, the falx cerebri, the tentorium cerebelli, these are really dense fascial sheets on the inside. Their tension can be influenced by myofascial structures just under the occiput.
Okay, very good. I think we're going to take a break, 5-minute break, and then we can come back and I'll start my presentation.
I'm looking forward to that.
Okay, all right, very good. So guys, take a break, get some water, bathroom break, and we'll come back. Yeah, thank you for letting me know. Let me go back here. Let's see in the chat here. Right is healthy, right side healthy, the one on the left side injured. Yes, it's very easy to tell. This is a microscope image of the healthy and injured patella tendon. So the image to the right, has the straight, the collagen fiber oriented in a organized linear fashion. And collagen is the principal protein of tendon, ligaments, and bones in the normal states and has great tensile strength. And to the left, it's an injured patella tendon. Disrupted collagen fibers with wavy orientation and fragmentation. The question is, what if we could change and influence the tissue tensegrity strength? Can we create healing and regeneration? And what I have discovered is absolutely yes, we can. And we're going to talk about tensegrity first. By the way, this image is credit to Greta Pathology. So tensegrity is a term first coined by Buckminster Fuller, who is an architect, philosopher, engineer, and poet, to describe his vision of a new kind of architecture, one that looked like it was built by nature instead of by humans. In contrast to the columns and break buildings of the past, which pile solid elements compressively, one on top of another, Fuller imagined a world full of unconventional structures that maintain their stability and integrity through a pervasive tensional force, hence the term tensegrity. So this is what his vision was like of the tensegrity model with struts and strings. And this is our tissue under microscope, the fascia tissue itself. How to influence the fascia tensegrity strength? Well, through the root of the fascia, the plantar fascia. Okay. What's so special about the feet and the fascia? The plantar fascia and its holistic connection upstream to the rest of the body, especially to the glutes. After working with many athletes from different levels of competition, I discovered the real root cause of dormant glutes, quad dominance, and compensatory movement pattern. It has to do with, you guessed it, not muscle alone, but with fascia. It turns out the elite athlete of today have different feet or fascial connection from the feet to the glutes and core. Okay, so on the left is a famous athlete, a slam dunk champion, Cardor Ziani. At the prime of his time, he had a 50-inch vertical. And this is me after reverse engineering the type of fascial tensioning that he's applying in the foot. What we can see here is that we both had bruised big toenails, extensor digitorum longus tendons, okay, and also the prominence of the anterior tibial tendon. Again, this is in a relaxed position, okay? This is not trying to forcefully trying to put my foot into the pattern that he's displaying. This is after the training of Hyperarch. At the highest level of competition, Division I Olympian or professional athletes, this pattern is more prevalent and significant. From the surface level in the relaxed position, the toes are curled and the integration from the feet to the ankle is extremely rigid and stiff. Stiffness in the ankle is one of the primary signs of elite athleticism. Unfortunately, mainstream trainers try to treat these individuals as abnormal by making them do dorsiflexion exercise to increase ankle mobility. From the fundamental research of plantar fascia, we know there are mainly three kinds of cells: fibroblasts, stem cells, and myofibroblasts. If the fascia tensioning level is different in the plantar fascia, what do you think happens to their holistic fascia upstream, holistic fascia connection upstream? And that's what I intended to find out. It turned out that the fascial connection from the feet to the glutes are vastly different from individual to individual. And this also correlates very well to their athletic ability, the level of chronic pain, fascia fitness. And this can be measured through movement and by live EMG. For example, the Athos EMG suit. Cardor Ziani is a French slam dunk champion. At his prime, he had a 50-inch vertical. There's many videos on YouTube you can find about his unbelievable athletic performance. Through interviews with him, I found out he grew up, just like many other elite level athletes, barefoot. Never wore the shoe since he was a baby, and often he lacked food growing up. That was his childhood. Lacked food, play sports barefoot. He first dunked while he was around 15 to 16 years old, when he still lacked muscle maturation. We know today from research that peak muscle strength occurs between the age of 20 and 30. So that tells me his athleticism cannot be due to muscle strength alone. Stiffness in the foot will create bruised toenails. This is because the big toe collides with the shoe. The extensor digitorum longus prominence is due to the fascia being tightened or tensioned. Now, why is it the key to the glutes is through the feet and fascia, not through deadlift or hip bridges or a million crab walks and things like that? The vast majority of the glute fiber insert into fascia. Problem with studying cadaver is that fascia is usually removed or dried up. We never actually study fascia of the glutes in the living condition. However, we could measure the EMG signals of the glutes between a fascia-driven athlete and the average person. Again, using technology, Athos EMG suit. That's what I've done. When the athletic person moves, the EMG registers mainly in the glutes. But when the average person moves, the EMG registers in the quad or hamstring. To truly engage glutes in all movement in a three-dimensional space, becoming glutes dominant, it has to be done through the fascial system. And the key is the mechanoreceptors, namely the feet and hands. Okay, so this is basically a image, a recording of a person that was moving, and he's quad dominant. When he moves, most of the reading would be in the hamstring and quad. And this is another person which is more athletic, and when he moves, the EMG reveals a different pattern. The readings are in the glutes more. And by doing the fascial training that we're doing, we can actually turn a quad dominant average people into a glutes dominant fascial driven athlete. But again, this takes time. This is me and Dr. Renan Machias, a neurologist who I worked with measuring my glutes response standing. So non-athletic individuals do not have high EMG signals standing. So the signals in the glutes is very dormant and do not have any control with the glutes. After building the mind-body connection and the fascial connection from the feet to the glutes, the reading is very high. We compared this with the standard EMG reading of a standard hip bridge. The results were very, very different. a hip bridge is where you lie down and then you try to thrust your hip up. The glutes EMG signals were vastly different than what I'm doing here. This experiment can be easily replicated using a EMG. So why is it so important, right? How did all this make sense, right? How did the elite athletes, why do they have this type of foot that is so different? And why does this give a superior fascial connection to the glutes? Well, it's because of the property of the fascia, one of the very important property of the fascia, viscoelasticity. This innervation to the glutes, soft glutes can be changed into hard glutes. Now, many of you that joining this training, joining this presentation, probably it's either soft glutes or in between. Only elite level athletes or Division I athletes have glutes when are very, very solid. When they start moving, the glutes through the property of viscoelasticity become activated automatically, and it will be very hard. Now, a very important factor to understand is the viscoelasticity, the property of substance exhibiting both elastic and viscous behavior. The application of stress causing temporary deformation if the stress is quickly removed, but permanent deformation if it is maintained. The key word is maintained. Since majority of the tissue in the foot is fascia, does it make sense a higher level of deformation means higher level of fascial tensioning? And the answer is yes. Because fascia displays viscoelastic property, it changes the state and shape permanently due to fascial tensioning. This explains why elite level athletes have feet that are morphed through hyperarch fascial tensioning or fascially molded feet. Elite level glutes function is tied to fascially molded feet, which I call the hyperarch mechanism. And the process that the body goes through to increase the fascial tensegrity strength is called hyperarch metamorphosis. And this takes time. It took me 10 years to realize the entire cycle of this process. Now, let's look at some examples in nature. What is happening in the elite level athletes and urban American feet? Exhibit 1A, which is the one that you see on the left, is a Olympian runner, Papa, and that's his foot. He actually run the race barefooted, and he does not need a shoe. As you can see, there is very prominent signs of extensor tendons, anterior tibial tendon prominence. Toes are slightly curled as a result of hyperarch fascial tensioning. Now, exhibit 1B, this is a typical American feet with the toes spaced out, no visible extensor tendons, no visible anterior tibial tendon seen, lost functionality of the toe joints, especially at the first joint of the big toe. The fascial connection to the glutes are dormant. So that means whatever the foot is doing, there will be no response in the glutes. Individual experience quad dominance, and when the competition gets tough, knee pain in sports. Now, how does this make sense? We also have orcas, 2B. Orcas raised in captivity with human controlled environment, no need to hunt, no need to exert large amount of force, doing tricks for a living. Guess what? The dorsal fins are sagged. This is like the anterior tibial tendon of the foot. Now look at the orcas in the orcas in the wild. Dorsal fins are straight. They're never sag. So there is a level of dysfunction that we are introducing to ourselves through the modern day society of wearing the shoe. Now this is done through, again, societal programming and also lack of activity during the developmental stages of the person. A lot of people, especially people who have medical backgrounds or medical degrees, will argue, okay, so we see a lot of these people with the hammer toes, they are having pain. That is true, but there's a story to that. There is a reasoning for that. There is the bad fascial tensioning, meaning For example, hammer toe. Too much tensioning of the toes are not healthy and could cause deformity, which can result in pain, difficulty walking, swelling, and other types of upstream biomechanical problem, for example, knee pain. However, there is a good fascial tensioning which you can train and monitor and modify properly over time. And that's the training challenge, is to concentrate in the Hyperarch mechanism that allows the foot to properly engage during movement. I like to use the term squeeze the grape, and increase the fascial connection to the glutes and core gradually and naturally over time. So there is a way that you can go around this, but again, you need proper training guidance so you can actually develop good fascial tensioning, which will mimic the results, what is happening inside the foot of elite athletes. Now, why is this? Is this a common occurrence? Does this happen in the world under our noses? Definitely yes. We know the Maasai tribe of Africa. They are one of the people who possesses the most effortless athleticism known on earth. They're able to effortlessly jump up and down barefoot or with a shoe, with a sandal, without any aid of hands. They can exhibit very high vertical jump capabilities. And there is actually an interesting study that was done on their foot, about 1,000 different individuals, and almost 99% of which they have the clawing foot formation. Now, this is not to my surprise. This should be a natural development of their athleticism or fascial system. They would have very high fascial connection from the feet to the glutes. Again, this can be measured. And of course, when you're fascial driven and glutes dominant, guess what type of your foot you're going to be using more? The forefoot. Because of the holistic fascial connection from the feet to the glutes will eventually lift the weight and suspend the body from the heels. And I'll demonstrate with some examples in later slides. So after we started reverse engineering this type of function of the foot, now our athlete can do the same. You know, this is a good example. I have a video on my Instagram and everyone can take a look. It's a same exact type of Maasai jump. You can jump with your foot to the glutes with a stiff ankle without any type of muscular strength. You should be able to jump pretty high and pretty well. And the body sensation will completely different. It's not going to be coming from the quads. It's not going to be coming from the lower back, but the body activation pattern will be the glutes and core, which is completely different. So a holistic type of jump is from the core and glutes rather than lower back and core. And if you observe elite athletes, especially Olympian athletes, especially the ones that can do very high vertical jumps using one leg, in the penultimate step, there is very little quad activation. It would be majority of the EMG signals will be coming from the core and glutes. So what happens when we examine the feet of elite athletes in all over the world, all different types of sports? What will you find? If what you say is true, then you should be seeing this type of pattern, right? Yes, we did the study. All championship caliber athletes have signs of hyperarch fascial tensioning. Stiffness in their feet, toes are curled to various degree depending on their sports. So some sports, it will show you there's more curling of the toes. It depends on the sport. If you're doing a sprinting, not necessarily, because there's no stopping. You just go. There's no change of direction. You just go straight. As long as you have the high speed, you're fine. Ronaldo, Neymar, Usain Bolt, Rafael Nadal, LeBron, and the good German athlete of all time, I think in my mind, Dirk Nowitzki, all have it. It's part of their biomechanics. Now the question becomes, what exactly are their feet doing? Can we replicate it? And if so, what will happen to the body? Nobody asked this question before, nobody. But we're the first to answer this. This is Dirk Nowitzki. Since we're working with our good German doctor, we're going to pick a German athlete. NBA champion, finals MVP, 14-time All-Star, NBA three-point contest champion, FIBA world champion, MVP is no different. The same type of fascial tensioning signs emerge. This is the exact hyperarch fascial training signs which I described with curl toes, prominent extensor tendons, and prominent anterior tibial tendons, or ATT, with good upstream glutes function. Just like there are ways we can measure muscular dysfunction, hyperarch fascial training has the methods to measure fascial connection from the feet to the glutes and the dysfunction in the kinetic chain. One way to do it, of course, is always through movement. Another way to do it is through the EMG. But if we know what we're looking for, we can measure this. The textbook explanation today on the sliding filament theory of muscle contraction explains the mechanism of muscle contraction based on muscle proteins that slide past each other to generate movement. Now, as you can see here on this diagram, the muscle fiber itself is shrouded or encapsulated by fascia. The pericynium, endomysium, epimysium, endomysium. These are all ignored in this theory of muscle contraction. How can you only describe the action from muscle fiber to muscle fiber when it interacts with fascia? The research conducted by Williams and colleagues from 2013 found that muscle force generation is much more intricate than has been historically taught over the past 50 years. Historically, muscle force generation has been explained by the sliding filament theory. This novel new study, however, uncovered that muscle force is generated in all directions and not just along the myosin acting axis. So pretty much it tells you this theory of muscle contraction is flawed. After years of research and working with athletes, it dawned on me, as healthy and fit I thought I was, when I was lifting 2 times my body weight, my fascial fitness was poor. Again, let me repeat that. I lifted 2 times my body weight, muscular strength, very strong, but my fascial fitness was poor. Still had knee pain. For example, I could not stabilize my ankle and hop for more than 1 minute, but they are natural athletes who can do way longer with lower muscular strength, to be specific, lower concentric muscular strength. The fascia sheath acts as a web of stability to keep the tendons and tissues glued properly. And when the individual has suffered some sort of injury, we will always find some sort of fascial adhesions. These adhesions tend to correlate to some of the important meridian lines and points. This is how we derive the hyperarch fascia health chart. By using a simple method of rolling and identifying the level of fascial adhesions, trigger points, and knots, we can get a good understanding of the connective tissue in the surrounding area of the injury. We're also investing in ultrasound technology that will clearly show this type of fascial adhesions in the future. So this is a tennis athlete I helped. And he started out with quad dominance, an oblique injury, chronic shoulder pain. This is the photo, these 2 photos apart, about 9 months. Okay. And the first one, he was applying hyperarch fascial tensioning. As you can see, there is no extensor tendons prominence at all. 9 months later, what's happening here? Aha, change. Both have hyperarch fascial tensioning signs, but the physical signs are very, very different. Again, the prominent extensor tendons, the anterior tibial tendon dominance, the glutes response. So I measure this person again for the glutes response, very, very high than before. And what the athlete Ben, who's a tennis athlete, experienced was increase in power, accuracy, and stamina. Most importantly, Ben no longer suffered from oblique pain, shoulder and rotator cuff pain, or quad cramps, which he often experienced when he was playing tennis before. Before working with me, Ben was ranked 50 in his age group, and we'll see how he ranks in a couple of years. Why am I so against weight training based rehab? This is not to bash anybody, but what we have found out is that weightlifting will generate fascial adhesions in individuals with low fascial fitness, much more than someone who has higher level of fascial fitness. Because the fascia is the first line of defense. When it comes to wound healing, the microscopic tears that the muscle training generates will accumulate the fascial adhesions over time, and it impairs the gliding ability of the fascia. This is not to mention, it does not solve the problem at the foundational level of the foot and ankle. When you do squat or deadlift with a foundational deficit, guess what type of neurological pattern you are developing upstream? That's correct, compensation. Ben's feet, the tennis player who I helped, was quad dominant before. And he also had quad dominant problems and weak shoulder. Once we increased his level of fascial fitness, the pain disappeared and his performance got better without lifting a single ounce of weight. Now, you might say, okay, wait a minute. Are you saying we should not lift heavy weights at all? Then how the hell do we get strength? How do we get power? Does fascia provide the strength necessary to move weight? Right? These are very tough questions, very good questions. And this is something that we ask ourselves. So when we look at the elite athlete shooting a ball from long distance with effortless delivery power and accuracy, we don't necessarily see big muscles. On the contrary, we observe the developmental stages of elite athlete. They were quite skinny around teenage years, where, again, muscle maturation hasn't happened yet. When they first show signs of elite athleticism, they do not have big muscles. This is nature. You cannot fight against nature. So how does nature do it without big muscles? Again, nobody asks this tough question. How did the elite athlete become elite athlete without lifting a single ounce of weight? Could there be a different mechanism at work here? Could there be a different way that the power is generated? The answer is a resounding yes. By replicating the Hyperarch mechanism, which stabilizes the ankle naturally and catalyzing fascia cellular changes in the body, we can innervate connect to the glutes at a level that was once only physically and neurologically available to elite level athlete. So this is my son, 3-year-old Josh. When he was born, his foot is already doing this type of movement, where the toes are curled, where the big toes are curling, and the ankles are very, very stiff. This is the origin state of the foot. There is no influence of the shoe whatsoever. Now, most people would say, oh, the toes are curled because they were wearing the shoe, is cramping up. No. All babies do this. If you observe nature, you will see it. Now, how do we know this? We put our theory to test. We stopped lifting weights and started training the feet, hands, and fascia only. The same way natural athletes are developed secretly under our noses. We also know today, after a decade of research and work, this is also training the way that the baby is doing this. This is also training the fascia, strengthening the upstream fascial connection to the glutes. Want more proof? Let's watch this video here. This is how a baby walks. I want you to notice the toes. They're curled downwards, and there is no dorsiflexion of the ankle. Stop right there. All the toes are very, very tensioned. Some babies, especially when they first learn how to walk, you will notice the fascial tensioning level especially in the toes, their nails will change color. So for example, if I'm grabbing something, right, your nails will turn from pink to white. Babies do this regularly, but we don't pay attention. Again, the Hyperarch mechanism keeps the foot and shin in a 90-degree angle as one unit. Also, there is no pronation or supination, because what is happening here is underneath the hood, it's trying to stabilize the ankle with fascia. It's providing tension to the fascia. fascia web surrounding the ankle. Okay, let's watch one more time. 90 degree. 90 degree again, it's locked. 90 degree. There's no dorsiflexion. So do not confuse bringing the toes up to the shin. Babies do not do that. One of my early experimental condition was barefoot. So does that mean just go barefoot, which should be okay, right? What about athlete that passed the developmental stages? It turned out barefoot itself is not enough to trigger the mechanism. And I tried to understand why. Because the foot has 200,000 nerve endings. After examining the past neurologically related experiment, David Hubel and Torsten Wiesel's cat experiments stood out, which made me understand that if we dampen the neurological stimulation to our feet during developmental stages, the same type of dysfunction could happen to our fascial connection, which means we might be able to develop our muscles, but our fascial system, namely the proper strong fascial connection from the feet to the glutes, is never developed or matured. So what is this experiment? In cats, David and Torsten experiments showed if a kitten is deprived of normal visual experience during critical period of its start of its life, the circuitry of neurons in its visual cortex is irreversibly altered. In each of the number of newborn kittens, one eyelid was suture shut. The kitten was allowed to grow up that way, and it reached adulthood around 6 months. Its eyelid was opened again. Recordings were made, and electrophysiological activities in each of the kitten's eye. The recordings showed an abnormally low number of neurons reacting in the eye that had been suture shut, and an abnormally high number in the other eye. Macroscopic observation of the visual cortex showed that the ocular dominance columns for the eye that had been left open had grown larger, while those of the eye that had been closed had shrunk. So what does this mean? That means if a healthy organ that did not go through the proper natural stimulation that we're supposed to get, the neurological development of that organ will not develop. For the eye, it was the sight, which was light. For the feet, it's the mechanical stimulation that we should receive barefooted, playing sports, but we don't get that. So we don't get the necessary connections from the feet to the glutes. This is very, very important to understand what is elite level athleticism, what is the average people have in their body. In primates, the same experiment have shown, but through a longer period of time, because primates, as you can tell, that the developmental stages are longer, up to age 6 months. Now, Austin Reason is the researcher, reared monkeys in darkness for the first 3 to 6 months of their lives. When these animals were then introduced into normal environment, they had great difficulties in distinguishing even the simplest shapes. It took them weeks or even months to learn how to tell a circle from a square, a task a normal monkey learns in few days. In humans, certain diseases can cause cataract, a total or partial opacity of the lens in one or both eyes. Cataracts can occur not only in adults, but also in very young children. Cataracts can now usually be removed surgically. Studies of individuals who had such surgery at various times in their lives showed that in humans, as in other animals, there is a critical period of development of senses for the sight, for the eyesight. These studies also demonstrate for the first time that early environmental influences and hence particular neural activity pattern during a critical period can permanently alter the neural connection in certain area of the human brain. Now, this is a screenshot taken from a very famous YouTube sensation, Lima from Brazil. Now all Brazilians, we respect their soccer skills, but guess how their athleticism is developed? Barefoot since a very young age. The critical development age for fascial connection would be, in my opinion, between the 6 and 16 years old, because you have to understand, a lot of elite athletes by the age of 15 and 16, they're already dunking without big muscles. If you are active and playing sports barefoot, you have a very good chance of developing extremely high level of fascial connection from the feet to the glutes and core. This again can be verified on using the ASOS EMG suit during movement. We're talking about live studies, not just sitting down or dead cadavers. We are talking about movement. Are you able to use your glutes? Is there any registration of EMG signals as you walk? If you missed out this golden window, there is still a chance by doing the Hyperarch fascial training, but it would take longer to develop and mature the fascial connection from the feet to the glutes and to the core. For example, it took us, Mark Dedica, 5 years to get to Division 1. And currently, there are 4 levels being identified in how the body connects from the feet to the glutes to the core. And it took me 10 years to understand this whole cycle. And this is Mark Dedica. He's 6'8". Again, I'm not sure, I'm 5'8", 5'7", but he's 6'8" now. We started walking when he was 13 years old. He came to me with chronic knee pain, tendonitis, and at the time tried PT but did not work. By building the fascial connection from the feet to the glutes, the knee pain stopped after 3 weeks. And 5 years later, he won the Division 1 scholarship at FDU. He's the only kid from New Jersey to get the FDU scholarship. Some people might say the curling is due to smaller shoes. That's what we see over again. But there are many photographic evidence that babies' toes naturally curl and stay close to the ball of the foot. And Michael Jordan said he didn't wear shoes since he grew up in the countryside. And this is where the story he almost cut off his shoes come from. He almost cut off his shoe chopping the wood barefooted. And as you can see, Michael Jordan, the toe and the curling of the toe is there. It's very different from someone who has no fascial connection from the feet to the glutes. Now, bonding is something a lot of people are probably aware of. By understanding the property of fascia, you will see this is a sign of bad fascial tensioning or bad fascial morphing. And it is due to, again, the property of fascia, viscoelasticity, the property of a substance of exhibiting both elastic and viscous behavior, the application of stress causing temporary deprivation if the stress is quickly removed, but permanent deformation if it is maintained. This property is what makes Hyperarch fascial training possible, because if you wear a shoe and you give bad fascia morphing, it will change the foot. But if you give the good kind and build that connection to the glutes, guess what? Your entire function in the glutes will change. Fascia responds to tension, mechanical stress over time. So this is the illustration of what's happening in the body. In the beginning, the reason that your glutes is soft as jello is because you never really developed the proper upstream fascial connection. And I have an animation here to show you how the foot actually developed over time. But again, it looks very quickly, but this takes months and years. It does not happen in the blink of an eye. It takes time. And this happens especially very, very quickly during the developmental stages of an athlete. If we ever want to come close to performance of an elite athlete, okay, such as Kevin Durant, James Harden, Kobe Bryant, we must live peacefully with knee valgus, meaning the knees are together. This movement pattern is safe under the tensegrity principle because these athletes are fascial driven. However, of a regular person with underdeveloped fascial system, this would be very, very dangerous because their body is built like a stack of bricks. The fascia is not working in their favor. Our focus should be helping average people to go from the muscle dominant to fascial dominant, instead of critiquing the elite athlete that they have bad form. There's so many people that tell these athletes, the best in the world, they have bad form. They have bad for squatting, they have bad for shooting because the knees are coming together. But this is everyone. All top level athletes do this pretty much. Using Athel's EMG suit, you can clearly understand what's being recruited during movement. Again, live movement, not a stationary type of movement, but live movement. In other words, we can literally measure ourselves as we change from quad dominant to fascial driven and glutes dominant. We can also use Mile-Town tool to measure the tissue stiffness. This is very important to understand too, especially in the ankle complex. As your ankle stiffness goes up, the tissue stiffness will change. We can also use pressure map to study the foot contact point. As the foot didn't develop properly, you would rely on a tripod system where your heel bear a lot of weight. However, as your fascia start to connect to the glutes, your heel no longer bear the majority of the weight. Let's take a look. Okay. I want to show you this video first. This is the slow motion. Look at the heels. This is the slow motion of Zion Williamson. I want you to understand how fascia suspend away from the heels. This is not something you can train by lifting weights. This only can be done through the level 4 fascial connection from the feet to the glutes. The higher level of the fascial connection, the body relaxes more, the body movement becomes more effortless. So relaxation is key for higher level fascial driven athlete. Level 4 athletes have special shooting challenges that average people do not understand or comprehend. It is true, it's not easier for athletic people to shoot because the body feels like it's being suspended. So the shooting challenges are there and you have to have specific cues to address it. And this is my foot and the area that identify as the contact point under the hyperarch fascial training. As your foot start to morph and develop, the only area of force that you will feel under the pressure map study would be in these areas. There is no tripod contact points. I know in the mainstream, they talk about the sesamoid, the pinky, and the heel, but not under the hyperarch fascial training system. This is the only area that you will be needing as you perform athletic movement. Occasionally, your heel will touch, but majority of the weight will be on the forefoot. And this is a chart where it demonstrates Kobe Bryant's injury in the chronological order. So I compiled this. What you can see here again, ankle spray is never innocent. It's the first signal or sign as tension is lost in the holistic fascial system. In the foot, because the foot to be without landing with fascial tensioning, the force is too great to be accommodated by the knee. So if the ankle is wobbly, for example, when you land, the force will try to seek a secondary stabilization joint, and that would be the knee. So landing with tension, the force is directed via the posterior chain. The proper technique of training the landing, training the change of direction will be very, very necessary to prevent any type of fascia-related injuries. If the ankle does not get treated properly, then you will have a holistic chain of problems that's going to happen upstream. So the number one thing that you have to really stabilize is the ankle. This is a simple analogy to understand between the loose unfitted fascia versus the tight fitted fascia, okay? Why is it some people, they are doing massages, they are getting better type of results, but why is it some people when they do myo releases, they get poor, right? This is a very important question to answer as well. The integration of the fascia and the underlying structure is very, very important. If there is a slack in the fascial matrix, the underlying tissue is not getting the benefit of the fascial remodeling. In other words, the actual conversion of the fibroblast to myofibroblast cells, when you have these myofibroblast cells, they're not necessarily integrated with your tissue properly. So how can it get better? It doesn't. So the first step of this training and strategy would be get rid of the slack. So meaning we're going to build this, make sure the fascia is hugging on and gluing to all the tissues underneath. This is our first case study. When we first started, Mark Dedica had 2 very bad knees, and that's his basketball coach at the time. And we worked together. I helped him. In 5 years, he got Division I scholarship. All not by lifting weights. We did not lift any weights. We only trained the feet. And now his feet start to resemble Dirk Nowitzki. So guess where he's going? And that's the news article announcing the men's team signing Mark Dedica. This is another gentleman I work with. His name is Mats Kofer Romelson, professional basketball player in Portugal, made all-star team after 1 season doing the training. Quote, I have felt improvement on my shot. I can now shoot stable NBA threes off the dribble. Shot 43% from the last 3 seasons on more attempts. I have not twisted my ankle since after started Hyperarch fascia training. After visiting you last summer in New York, the ankle sprain was a regular feature for me every season before. I had 5 sprains last season. I also haven't experienced knee pain, something I have dealt with in the past with jumper's knee, especially at the end of the season. Not to mention, I also have partially torn meniscus. On a side note, right, by the way, this is such a small world. They're also a family friend of Dirk Nowitzki. Ankle pronation, what can fascia do? This gentleman here, his name is Ayas, is from France. He went to the chiropractor. Chiropractor diagnosed him having pronation of flat foot problems, as you can see here, especially on the right side. The alignment is off. After 3 months, we're able to get his leg and ankle straight. Because of this pronation, he also had shorter, the hip alignment was off. This side was tilted. Once we address the root cause of the problem, the hip alignment start to go back to its original position. Okay. And again, this is something that when he consulted with the chiropractor said this cannot be fixed. There is a solution for this. He suffered 4 years of flat feet, collapsed arc, and hip imbalance caused by overpronation. And every time when he plays soccer or football training, he would end up in extreme hip pain and soreness. But we're able to help him in 12 weeks. Another case study. So you're saying you can address the pronation. What about supination? Sure. This gentleman here, his name is Bradley. He played basketball. He used to have a very severe case of ankle supination, as you can see here, especially on the right side. And guess what? This side's fascial connection from the feet to the glutes is also very poor. Quote, I had to walk really slowly or take off my shoes after games. It was a lot of pain. Also, on both sides of his feet, he had sesamoid pain. That means the contact point is also off when the fascial connection is poor from the feet to the glutes. After 12 weeks of Hyperarch fascia training, this is our result. We actually pushed, we're able to modify how the fascial connection, positioning the ankle. Again, this is not a segmented body part. We always talk about the holistic fascial train upstream. So by changing this, the fascial tensegrity strength of the leg, the glutes are also helping in keeping the ankle in its neutral position. After 12 weeks, he said, I don't really have pain anymore. Now I come home, I just take a shower, wake up the next morning, feeling fine without even having to roll. Of course, his basketball game also improved as a result. Okay, Achilles tendonitis. Now, when we talk about fascia, when we talk about the fascia integration from the ankle to the glutes, Achilles is one of the very important tendons. Now, if the integration, again, from the foot to the glutes through the fascial connection, it's weak, of course, you could have problem with your Achilles, you could have problem with your anterior tibial tendon, you could have problem with your peroneal tendon. And this gentleman here worked with him using our proprietary technique and training. Not only his Achilles pain stopped permanently, and he also increased his running speed. Can fascia help with knee pain? Yes, that was a primary goal that I had when I started this journey. Dave Alteri has been having osculoscalar knee pain for over 8 years. The problem is he reintroduces it every time when he plays. And that's a challenge for any coach or any PT, is how do you prevent it from coming back? The key here is you have to not only increase the fascial connection from the feet to the glutes, but you have to examine the biomechanics of landing. You have to land properly with fascial tension. A lot of people, when they wear the shoe, their understanding of the ground force is completely altered. They land with the whole foot on the ground. That's not going to direct the force to the glutes. That's going to go to the knee. Also, when you land, if the ankle wobbles, it's going to go to the knee because, again, the ankle is not stabilized. Low back pain. This gentleman here is Lucas. He used to always say after practices, he needs to lie down. This was how he felt every time he plays sports. Even sitting down for a little bit, longer than 10 minutes, the overall quality of life is very low. Just like many other people experiencing low chronic pain, he tried painkillers, creams, massages, and so on, but the pain will go back immediately, and he has to keep up with the regimen. We work together. Now, low back pain is also gone. Why is this working? Again, we're building the fascial connection, the fascial tensegrity strength from the feet to the glutes. And anytime that the glutes is fully activated and being used, the lower back will not compensate that much. This is how we can permanently get rid of the issue from its root. And why this is working? Because a lot of people during developmental stages of their lives, their fascial connection never fully matured. So we have a chance to modify it. Okay, this is a big one. On shin splints, a lot of people who play soccer or run marathons will run into this type of problem. This happened to Bryce, who was the Division I level cross-country runner at the time. He suffered debilitating shin splints for 8 years. And what caused him to suddenly go from running, flying to running, that turned him to a painful drudge through the mud? That's how he described himself. He saw the PT and did whatever they prescribed. Again, the PTs are right now, they're only doing muscular-based exercises. The pain never went away. And from that point on, we started doing Hyperarch fascial training. And right now, 5.5 months later, after Hyperarch work, his pain is gone. Best of all, every day he go out at least one hike, about an hour and a half with no pain. That's the progress that Bryce has made. It is possible to break the cycle if the muscular training is not working for you. This gentleman here, very interesting case. He has a hip labral tear, and very interestingly, he's also a transsexual. Nobody could tell, right? He used to be a female, and now he's a male. He's a boxer. He's a professional boxer, and he had accumulated a lot of pain over the years. And also he had the hip labral tear. He saw my work with Coach Ben, who also had problem in his lower back for 10 years, started to work together with me. After 12 weeks, he says, well, he didn't believe it. He says it works. I feel my quote, I feel like my hip is in a better position than before. Instead of constantly grinding into the part where there is a labral tear, it's actually being held and supported better by fascia pad. My stability and balance are way better. I used to fall over when I was boxing, even though I had decent footwork. I'm much more able to move and pivot around. My punching power has increased. I'm definitely throwing shots harder, and I can feel my core and my glutes engage, end quote. And we have done studies on the punching power. On average, we can increase about 28 to 33%. That's a large number in 12 weeks. Tennis elbow and hip flexor. This is another case that I worked with. The person had 6 months, began his PT work to fix his tennis elbow. And after 1 month, it didn't get better. It actually got worse. So he was, considering just living with, taking painkillers, wearing a brace, until he found about hyperarch fascia training. We did the work together. What happened was that the pain, the 8 months of tennis elbow went away, and it's completely gone. And his hip flexor also had the problem, and that was already fixed as well. Again, we're working on the fascial tensegrity strengths of the body. We do not lift any weight. You have to address a fascial-based problem with a fascial-based solution. Can it help with IT band? I mean, we talk about IT band, how elastic it is, how it's different from other primates of the body. Yes, but the IT band cannot be working in isolated fashion. It has to be, again, connected properly through fascial tensioning, meaning a proper fascial connection from the feet to the glutes has to exist. The glutamus maximus and medius has to be firing properly. This person had IT band, patella tendonitis, and an anterior pelvic tilt. Often complains, my hip flexors are too tight. My glutes and abs are not strong. I have to stretch it out. That was the only solution he had before. And he went to many doctors, many PTs. When people realize that their foot does not have the proper fascial tensioning level as they should, they can make a change. And now he's no longer having any of this. He's much more cognizant of his foot hip position during the day, and there is no more anterior pelvic tilt. Again, we're talking about how fascia can stabilize the tissue underneath the hood, right? So the fascia is a gelling component. There are people that have genetic predisposition to have very higher level laxity in their joints and tendons. For example, I have a case here, patella tendon subluxation. Okay, and Aziz, and he used to have this tendon. He would just walk and run, and suddenly the tendon would just go out of its natural position. It would just come off. And he tried many type of treatment, lifting weights in the quads, getting quads stronger, did not work. They did the hyperarch fascia training after 8 weeks. Okay, not instantaneous. After 8 weeks, the results were amazing. Quote, the most consistent hyperarch training I did was around 8 weeks. The results were amazing on the kneecap, where it actually feels like it fits into its place, not loose like how it used to be before. Again, we're trying to address the fascial problem with a fascial solution. Plantar fasciitis. This is an age-old problem. I think this made even into a daytime television. No solution for plantar fasciitis. It's an overuse injury. The shoe is not good. Let's wear an insole, right? Okay. But what is actually happening is there is segmentation in the body. The fascial connection from the foot to the glutes is not optimal at all. For example, if you're a runner and you're taxing your body every single day, the level of fascial fitness required is also very high because it has to stabilize all your joints. It has to keep your body together. Kevin Narlin no longer have this type of problem after doing fascial training. Okay, he also removed his insoles and orthotics. I mean, this is just a small subset of what we can do. For each example, we have many, many cases. And this is our, I think Yuri is in the group today, in the chat today, in our webinar today. This is son, Noah. Particular issue they had was the Sever's disease. Now, what is a Sever's disease? It's one of the most common causes of heel pain in growing children. It occurs when the Achilles tendon pulls on the growth plate in the back of the heel. Symptoms include swelling, redness around the heel, limping or working on toes, stiffness in the feet upon waking up, pain when pressing on the back of the heel. Mainstream believe this is a repetitive stress on the growth plate that causes pain. This condition usually affects children who are physically active, especially in sports that involve a lot of running, jumping, and other high-impact activities. However, it can also affect less active children who are going through growth work. This is when the bones, muscles, and tendons grow at different rates, which may increase the pull of the Achilles tendon on the heel. While Sever's disease is typically resolved once the growth plate closes and is replaced by solid bone after puberty, the pain that it causes may last a few years until it happens. This is their explanation. However, mainstream disregard fascia. They do not understand currently that the fascia can help the body stabilize, so it doesn't rely on single tendon type of action when the person moves. So after 12 weeks of training, the pain is gone. Does that mean he stopped growing? No, he's still growing today. And quote, from just fascial training, he has not had any issues with the knee and the heels, because every time when you have a heel problem that is very weak from the foot, there is likely to have an upstream reaction as well. And what is even more amazing is, quote, watching him doing the 100 meter and how much smoother it was because the gait was better compared to his prior gait, and how he could barely walk every time we came back from baseball game. You can just see more athleticism building in him. And after 9 months of training, Noah used to have one of the lowest in class when he first started. 9 months later, it become one of the highest. So of course that, Noah and his dads are very pleased. Wait for those questions. I'm going to answer after I go through all the case studies. This is a very, very unique case. It's called calf atrophy. As you can see here, the right calf is significantly smaller than the left calf. What happened with Bryce here, he did a lot of different type of PTs and alternative methods. because he was really affected and desperate and wants to make the change, because the one side of the calf, it doesn't matter how many calf raises he does, it just doesn't get better. And the understanding was, okay, the calf muscle is weak, so let's make it stronger. But if you have a problem with the fascia, it could impede the healthy blood flow that could bring the right amount of nutrient and oxygen to the nerves and muscle tissues needed for normal function. That was never considered. Again, because mainstream disregard fascia, does not consider fascial adhesions in the treatment. So in this case, we worked on the fascia. This is 12 weeks of result. This started to happen, start to balance each other out after 8 weeks, which correlate very well to the conversion of from fibroblasts to myofibroblasts. Now the challenge is, how do you introduce enough myofibroblasts so it doesn't cause fibrosis? That's the key. All right, let's go to the next one. Growing surgery scar tissue disappeared. This message is what I received from Tyler. He had growing injury and surgery over 10 years ago. And he was never able to move his hip. He's never able to do an air squat. It hurts. Also, there's a big scar tissue. What he noticed is after 2 weeks into the Hyperarch fascia training, the scar tissue in his groin disappeared. It used to be the size of a shoelace, but it disappeared. And now we're on to the 12 weeks. Majority of the pain is gone. Majority of the adhesion is gone. He can do air squat. And now he walks the dog daily. When he walks the dog, he feels the glutes. And we're going to get a testimonial from him. It will be uploaded on my YouTube channel. This is a very important case for soccer athletes, people who compete at very high level. Again, fascia problems have to be solved by fascia solutions. Tried mainstream rehab, limited results. He was at the point of getting a surgery because the mainstream PT had failed. So what we did was, again, find out what his current fascial connection is. When we did our assessment, find out the side where he had the growing injury was very, very poor. We also found a lot of fascial adhesions on that side. We applied our fascial training, and this is what he had to say. Quote, I had my growing injury for about 3 months. Nothing seemed to help. I did PT and did gym work. PT was kind of useful, but when I started Hyperarch fascia training, I really started to feel better. Now I'm fully recovered. Your work has helped me a lot with performance and my strained groin and strained ankle. It's gone. He is a competitive athlete in the UK. This is a special case, and it's for an older lady. And her name is Alan. She has arthritis and Morton's neuroma. Okay, so let's take a look at the picture of the foot. This is before, this is after. So as you can see before, there's what I was explaining to you guys was the bad fascial morphing and bad fascial tensioning, right? So some of these toes are bunched together, and these are loose. These are loose. Also, notice on top of the toes, the foot, there is no high level of fascial tensioning, right? We worked together. He did 3 years of, he did not want to get a surgery, and he had 3 years of intense pain in the foot, knee, and hip whenever he climbed stairs or even just walking. He tried Qigong therapy, acupuncture, physical therapy of 3 years, has been taking Advil for 3 years. Anytime when the pain becomes unbearable, after working with me, he can walk 5 to 7 miles a day and 95% pain-free. The good doctor mentioned about EDS, hypermobility. Hyperarch fascia training is very, very effective for hypermobility people. Why? Because genetically, these people have weaker fascial connection, from what I found out. And also their foot tend to be flat as well. And this gentleman here, his name is Shem. And Shem is from the UK. And he had been struggling with pain and injury for 20 odd years. And he also tried physio for 12 years, just never stopped physio, because every time he played basketball, he will have foot pain, ankle pain, Achilles pain, shin pain, back pain, shoulder pain. So many joints are hurting. The pain starts to disappear after we strengthen the fascial connection from the feet to the glutes. About week 5 and 6, it starts to disappear. And 8 weeks later, all his injuries start to disappear. 12 weeks later, he realized his foot started to have arc. And this is a picture of that. And now he used to have a bag of rehab tools. Now he doesn't need any. Those rehab tools are sold. And we are still working today to get him better, because right now he wants to be playing competitively in basketball. And we haven't had any type of relapse for a very, very long time. This is one of the perhaps the most important understanding of last year, is that the hyperarch fascia training can influence the deepest layer of fascia, which is the arachnoid layer, which goes from all the way from your top of the brain all the way down in the spine, and it's within the spinal cord. Now, a lot of people have this condition called arachnoiditis, or AA. When this type of condition happens, it usually could be because a epidural needle inserting into the spine, creating a adhesion there, fascial adhesion. The fascial adhesion doesn't get cleared by itself. It creates fibrosis. Then later on, it causes enormous amount of pain in the body because it's in the spinal cord. So your whole body will feel terrible. And there's many, many symptoms, such as ear ringing, trouble sleeping, incontinence, back pain, couldn't sit for more than 3 minutes. And when the pain is so bad, the person has to either lie down and sleep or take heavy doses of anti-neuroinflammatory drugs. There is no cure. There is no cure. So if your spine, for example, is severed by accident, there's bones that punctures the arachnoid layer and it creates adhesions, you're pretty much done from the mainstream perspective. Not so much when we apply our knowledge of fascial training. We actually can influence the holistic fascia connection. This is very, very exciting, because after 8 weeks, she reported 0 flare-ups from the adhesive arachnitis. She has been having these conditions for over 6 years. And also, we're going to take an MRI to confirm that the actual injury site has healed. So this is a very, very big deal. And this is why I want to work with academics to make this mainstream. It's very, very important. Case study 21, surgery rehab. This particular case is after a Achilles rupture and surgery. As you can see, week 1, when the gentleman came to me, his right calf is significantly smaller. That's due to, again, atrophy, because of the injury on the fascia side never gets addressed. So it prevents the proper nutrition to the actual muscle tissue itself. Again, he was prescribed to do many, many calf races, but it does not help. In 5 weeks of training on the fascia, increase the fascial connection, increase the myofibroblast level at the correct level, not fibrosis, we're able to balance this condition. Okay. Oops, let me go back. Surgery rehab after ACLs. Now, how many people have heard of ACL? This is a very common injury in football, in basketball. Usually the mainstream rehab process involving strengthening the quads, calves, and also doing hip bridges using muscular exercises. When you do these type of isolation exercises or compound exercise for that matter, it is muscle-based exercise. It does not increase the fascial connection level from the feet to the glutes. To do that, you have to increase the fascial tensioning level in the foot properly. You have to overcome not to introduce bad fascial tensioning. You have to overcome not produce too much, so you create fibrosis. This is the result. No knee pains after 3 ACL tears. And for the first time in 9 years, Gabriel, a professional athlete, soccer athlete, reported for 9 years he had knee pain, and for the first time, there is no knee pain. And Gabriel also is a sports science student. He told me that there is no mention of fascia in his education at all, and he has to write papers about muscle. Okay, this is another surgery recap case. His name is Shay. He's a basketball athlete, a young person, used to have a lot of knee troubles and also shoulder and elbow issues. When he tore his knee, he received a surgery that removed part of his meniscus, and he had tried 3 weeks of PT before coming to me, and the swelling wasn't going down. And 4 weeks later, this is what you can see. Because the fascia is also working very closely with the lymphatic system. As the lymphatic system doesn't have a pump, by working with the fascia, you can increase, accelerate the regeneration process. And that's what we're seeing here, which is just great. I mean, this person I'm still helping with today. We want to get him to the next level of competition. Case 22, elbow and shoulder tendonitis. Now this guy tried everything. Physio, eccentric loading, isometric loading, rest, massage, myofascial release, instrument-assisted soft tissue mobilization, cupping, dry needling, BC, hyaluronic acid, collagen, bone broth, turmeric, curcumin, MSM, black seed oil, you name it. Also BPC 1557. Some of the therapy helped, but only the short term. Started with Hyperarch fascial training, things are improving fast. There is a natural way for the body to heal, but unfortunately, because our segmented understanding of the body, we were not providing these people with the right solutions. Okay. And finally here, tight-fitted fascia grants underlying tissue the protection of the fascial web, as well as the healing benefit of myofibroblast cells. What have been known and accepted in this field is that through mechanical tension, we can convert fibroblast cells to myofibroblasts, which is essential for connective tissue remodeling during wound healing. Sometimes an unregulated myofibroblast causes adhesions or fibrosis. However, through Hyperarch fascial training, we have discovered a way or window to manage this naturally and control the balance between physiological tissue regeneration and pathological fibrotic response. We believe it's the slack in the fascia that could sometimes cause uneven distribution of myofibroblast cells. Again, this has to be studied into further, and with the help of forward-thinking fascia researchers like Dr. Robert Schleip and more. We want the whole world to study this. And this is why we are sponsor at the 2022 Fascia Research Congress. And potentially, we're selecting 10 PhDs to sponsor. You know, if you are interested, contact info@fasciaresearchsociety.org. We want to open dialogue and discussion with academics. Since I have years of experience on the clinical side, now it's time for scientific scrutiny. Let's go. Finally, I'd like to thank everyone today for coming. 2022 is the year of fascia. We're entering a new age of fascial fitness. For the longest time, there was nothing on the fascia side that can generate power from the body like what we have seen in muscle training. The work we do will change that and upset the scale balance and disrupt the entire industry. Join me and Coach Ahmed at the 2022 Fascia Congress in Canada if you want to work with us. Please schedule a call on my website and we can begin to work. Thank you. All right. I'm opening up for questioning.
I don't have a question. I just want to express my surprise.
Yes.
Chong, I thought I was the main speaker and you were some add-on. I was completely wrong. Your presentation has been the main thing, and I can now understand why it took you 10 years to develop that. What you have presented is profound. I can judge that because I have a pretty wide overview on the field. It answers many of the questions that we just have been discussing in Padua during the week-long dissection, which we did. For example, examining the force transmission from the gluteus maximus, because it's not active when it was supposed to be. And it seems to be an envelope stiffener. And I think your explanation makes a lot of sense. So during listening to you, I made this one here. It's very similar to your oranges, that there are some muscle in the body, and the gluteus maximus seems to be mainly doing that are not pulling bones closer together so much, but they are increasing the surrounding tension, not only on one side of the leg, but even on the front of the lower leg. And that explains the very nice pictures that you have shown to me. So I'm very intrigued. Your explanations make a lot of sense. And I look further to collaborate with you in the future. So this is my complete surprise. I had not known your name before on this side of the Atlantic. And I thought you were some local hero who wants to promote his work via fascia research, and I was completely wrong. It's very embarrassing. What you have presented is very profound. I want the audience to know that. And from my perspective, it makes a lot of sense. And if you take that into athletic training, that and the many examples that you have demonstrated, that should make a big difference. So thank you very much for allowing me to share this almost historic moment where you share all these insights with me.
Thank you.
Thank you.
Thank you. Yes, thank you. I appreciate your comments and feedback, and I'm looking to bring this to the world in Canada this year. And definitely I open to any type of scientific scrutiny. And, you know, double-blind studies, twin studies, we're ready. And we're going to see a lot of results, because in the past 10 years, I have poured a lot of my life, blood, sweat into this work. And we finally found a way to balance the fibrotic response of the myofibroblasts. And this is the work of 10 years. So, you know, I'm very happy that I can share this stage with you to showcase this work. And I believe this work will help a lot of people, especially people who currently under the mainstream umbrella has no cure. There is a way to change the outcome of that result. All right. How do I become a fascia coach? Well, we're not open yet, but once we go to Canada, when we get more academic study on these things, there definitely will be certification coming up. Set pressure point should only be on the second. How does that translate into change of direction like American football? It does, because whenever you change direction, if you are using your glutes, again, this is a gradual process. You can use the glutes to change direction. Then the foot will use the main part of the second toe, second metatarsal area to handle the force. That's the best optimal area that you will develop. And this happens over time. 4 stages of metamorphosis, sure. I can discuss a little bit. I mean, we're running low on time. I have a video on this on my social media site explaining the 4 stages. You can take a look of what a body will go through. Basically, you have to build the fascial connection from the foot to the glutes. And then from there, you can build the connection again from the glutes to the core. Now, when you reach there, the body becomes fascial driven. What are the joint cracks? Should the crack or not? That depends. That really depends. There's a lot of reason for crackling joints, and it really depends on what the condition is. You want to see a doctor first before working with me. Any other questions? I think we're good. So thank you, doctor.
Thank you very much. You found that very inspiring. I will look up more muscles, not just the gluteus maximus, which is the most voluminous muscle that we have in the human body, and also no other animals has the gluteus maximus as the strongest hip muscle, but it explains our jumping ability and our long leg stabilization. But I think you mentioned the core muscles, so the transverse abdominis is also a more acute tensioning muscle and not like the rectus abdominis, a bone-to-bone shortener. And we recently also in Padua looked at the biceps brachii. It has a secondary insertion into the whole antebrachial fascia, so very much like the gluteus maximus. And probably that's different training that you would emphasize that secondary attachment to the lower arm. So it's not attaching to the radius of the ulna, but just tensioning the envelope. So I think I will take your excellent presentation. Of course, the gluteus maximus is the most important one, and it will build up the arch in the foot even. But even for the javelin throwers, we will look now, where do we have muscles that are not shortening the distance between the bones only, but that they are taking the slack out and increasing the pretension in the suit, in the membranes around it. So that is a very inspiring topic. Thank you very much. I hope we can collaborate more in the future.
Yes, we definitely have to collaborate because the work cannot move forward without the help of forward-thinking academics. All right, have a good one. Thank you very much again. Stop share.